Well, welcome everyone. My name is Dr. Colette Salm-Schmid. As the chairperson of the Education Committee for the National Accreditation Program for Breast Centers, I'm pleased to introduce the special education session on the unique needs of patients with metastatic breast cancer. The NAPBC accredits breast programs across the country, from academic programs in big cities to committed rural programs and everything in between. This special educational program on metastatic breast cancer is designed to explore multiple perspectives to assist centers in meeting the needs of this special population. We want to give back and share this information with you. Next slide, please. Just a few details about the webinar. All participants are muted during the webinar. For questions, please use the question pane, including any technical issues you're having. Questions will be answered at the completion of all the presentation if time permits, and will be answered and posted on the website, or can be directed to the speakers. Please complete the post-webinar questionnaire at the end, which we'll email to you. Right now, you can just sit back and join me as we all become inspired by this unique presentation. Next slide, please. We're recording the webinar and it'll be available for CME on our learning management system. Details will be given at the end of the program. Next slide. Disclosure information was obtained on all participants. Next slide. Please note that these disclosures for the planning committee and presenters are listed here. Next slide. Learning objectives for the session are as follows. We're going to learn about recommendations for treatment for the emotional and social needs of patients and the unique perspective of a patient with metastatic disease. Next slide. So let's get started. Please help me welcome the moderator of this session, Sally Werner, RN, BSN, MS, HA, who is the Senior Vice President of Affiliate Relations and Strategic Growth for the Cancer Support Community in Washington, D.C. Take it away, Sally. It's all yours.
Thank you so much, Dr. Salm-Schmid, and welcome everyone to today's webinar and presentation. Next slide, please. It is my distinct pleasure to introduce you to our panel of speakers today. First, I would like to introduce you to Dr. Joanne Mortimer. She is the Vice Chair and Professor of the Department of Medical Oncology at the City of Hope and the Director of the Women's Cancers Program. Dr. Mortimer has participated in clinical trials in breast cancer for over 30 years. Her research has focused on assessing the effects of systemic therapies on cancer and normal tissues. Many of these trials have utilized functional imaging and other biomarkers. She is studying the impact of toxicity on breast cancer disease, outcome, and quality of life. And she and her colleagues were the first to report favorable cancer outcomes for women treated with tamoxifen who experienced hot flashes. Dr. Mortimer received her medical degree from the Stritch College of Medicine at Loyola University and completed her internal medicine residency and an oncology fellowship at the Cleveland Clinic Foundation. Next, I'd like to introduce you to Professor Matt Lascalzo. Matthew Lascalzo is the Lillian Elkins Professor in Supportive Care Programs in the Department of Supportive Care Medicine and Professor in Department of Population Sciences. He is also the Executive Director of the Department of Supportive Care Medicine and the Administrative Director of the Sherry and Les Biller Patient and Family Resource Center at the City of Hope National Medical Center. Professor Lascalzo has over 40 years of experience in caring for cancer patients and their families. He is highly recognized and sought after for his strategic mentorship of leaders across disciplines. Professor Lascalzo has focused mostly on pain and palliative care and the implementation of problem-based screening programs, gender-based medicine, and problem-solving therapies. Last but not least, I'd like you to introduce you to Shirley Mertz. Shirley Mertz is a former high school principal and has lived for 18 years with metastatic breast cancer. Wanting to help others with the incurable disease, she trained to become a research advocate. Shirley serves on the ABC Global Alliance Board of Directors, is president of the Metastatic Breast Cancer Network, and a founding member and past chair of the MBC Alliance, and of course a patient advocate with the TBCRC and the Aurora USMBC study, and a member of both the University of Chicago and Baylor University SPORES, a Komen advocate in science, and consumer reviewer for DoD and Komen grants. She is also an author on a number of publications about MBC. Please welcome our panelists, and now I would like to hand it over to Dr. Joanne Mortimer.
Dr. Mortimer, you may need to unmute.
Good day, everybody. It's a pleasure to be here. I have the yeoman's task of talking about the management of metastatic breast cancer in 10 minutes. And so let's get going. Next slide. Let me start out by talking about the basic landscape of metastatic breast cancer from a medical oncologist standpoint. So I think it's important to realize that only 5 to 6% of women who have metastatic disease present with metastatic disease at diagnosis. That is, they have not been previously treated for early stage breast cancer. As a rule, women who present with metastatic breast cancer do significantly better and live longer than patients who present after being treated for early stage breast cancer. So the majority of the patients that we see with metastatic breast cancer have previously been treated with surgery, radiation, chemotherapy, and endocrine therapy, in some combination, and have subsequently developed metastatic disease short or a long time after initial diagnosis. Why that's an important point to stress is that this means that these women come with toxicities from their prior therapies, their surgical toxicities, and more often their chemotherapy toxicities, such as neuropathy. And these things can hamper our ability to give adequate chemotherapies with overlapping toxicities. It's always important to stage the patient, and the staging generally is with a CAT scan and a bone scan. Although PET CT scans may identify more disease than we see on a CAT scan and bone scan, generally because of cost, insurance will only cover a CT scan and a bone scan. Tumor markers, and we don't need to draw all 3 tumor markers, CA27, 29, 15, 3, and CEA. Pick one, because the purpose of it is that if it is elevated, we will use it to track the response to therapy, hopefully decreasing the need to do repeated radiographic studies. Every patient with newly metastatic disease or recurrent breast cancer requires a biopsy. And the biopsy is important, obviously, for confirmation of recurrence of disease, but importantly to determine the phenotype, the hormone receptor status, and the HER2 status of their disease. It is not uncommon for 20 to 30% of patients to have a different hormone receptor or HER2 status on a tumor recurrence that differs from the original primary tumor. So it really is critical to get a biopsy. So patients are then categorized as being hormone receptor positive, HER2 positive, or triple negative. The majority of the patients that we see are hormone receptor positive and HER2 negative. It's about 70% of patients, with 15 to 20% each being HER2 positive or triple negative. Another important principle in managing metastatic disease is the management of bone metastases. Any woman who has even a single site of bone metastasis should receive bone-directed therapy. And those bone-directed therapies are either bisphosphonates with zoledronic acid or Zometa, or denosumab, an antibody against anti-rank ligand, Xgeva. Previously, we administered these drugs on a monthly basis, but we recognize that atypical fractures can occur, and the data support the administration of these drugs every 3 to 6 months being equally effective in decreasing skeletal-related complications, such as fracture, need for orthopedic stabilization, radiation therapy, spinal cord compression, or hypercalcemia. And the last principle in managing metastatic disease, which is somewhat new, is that all women should have germline testing. They should all undergo testing for BRCA 1 and 2. Next slide. So I realize I don't need to explain the difference between germline and somatic testing, but germline testing being your own genes from your parents. But as we move forward and we talk about managing metastatic breast cancer, I'm mostly talking about genetic testing for somatic testing, where we're looking at the genes of the cancer, which may help to direct systemic treatment. Next. So first, let's talk about hormone receptor positive breast cancer. Again, this is the majority of the patients that we see. First line therapy for a patient with metastatic hormone receptor positive, HER2 negative breast cancer is with endocrine therapy and a CDK4/6 inhibitor. So these are the three drugs, the abemaciclib, the ribociclib, the palbociclib, the three agents that are used concurrent with whatever hormone you start out with. The purpose of these CDK4/6 inhibitors is to improve the efficacy of endocrine therapy. And their addition to treatment has resulted in a doubling of response rate and a doubling in duration of response. So that first line therapy, when patients respond, the median duration of response is roughly 2.5 years. If patients respond, then great, we continue them on treatment until they have disease progression. And that star there indicates that if on disease progression, we should do molecular testing. If they fail to respond, then chemotherapy is the treatment option, because it's unlikely that a patient who doesn't respond to first-line endocrine therapy is going to respond to a subsequent endocrine therapy. Second-line therapy for hormone receptor positive breast cancer continues to be endocrine therapy. So if you're premenopausal and got tamoxifen and an LHRH agonist, you get an aromatase inhibitor. If you started with an aromatase inhibitor as a postmenopausal woman, you go either to another aromatase inhibitor or to fulvestrant, a selective estrogen receptor downregulator. So I wrote in the star there that this is molecular testing. And for second-line therapy, the value of molecular testing is identifying women who have certain mutations. So mutations in the ESR gene may predict lack of benefit to one of the aromatase inhibitors. Identification on somatic testing may identify a patient whose tumor has a PIK3A mutation, in which case alpelisib or Piqray is the treatment of choice to combine with second-line endocrine therapy. And so again, patients who respond and continue to respond, you continue on that treatment until disease progression. Or if a patient does not respond, then chemotherapy is the next line of treatment. So third line therapy with endocrine therapy, we really don't run out of endocrine therapies because we have 3 aromatase inhibitors. We have fulvestrant, the selective estrogen receptor downregulator. We have tamoxifen. And we have a history of using drugs like progestational agents like Megace or high-dose estrogen. So until the patient is truly resistant to endocrine therapy, only then do we move to chemotherapy. Next. Okay. The next population of patients I'm going to talk to are, of course, the area where we have the most excitement, the HER2 positive patients. And first-line therapy is very well established. Trastuzumab, pertuzumab, and a taxane. And it doesn't matter if your taxane is docetaxel, nab-paclitaxel, or paclitaxel. We know that pertuzumab added to trastuzumab and a taxane results in a prolongation, not just of disease-free survival, but of overall survival. So that's first-line therapy, and we continue first-line therapy until the disease progresses, or if there's a lack of response, then we go to second-line therapy. But know that the duration of chemotherapy with first-line treatment is usually 6 to 8 doses. Most women cannot tolerate indefinite docetaxel or paclitaxel. And so generally what happens is that you put the patient into a good remission with all 3 drugs. And once they're in remission, you stop the chemo part of it and continue on maintenance trastuzumab and pertuzumab. In the initial study of this triple combination, there are women who have been on trastuzumab and pertuzumab for 136 cycles. So this is incredibly effective therapy. With disease progression after response, second-line therapy is either with the antibody drug conjugate, TDM1, or with the oral anti-HER2 drug, a small molecule, tucatinib, with trastuzumab and capecitabine. Frankly, it's hard for most women to tolerate all three of those drugs, and often we drop the capecitabine. Third-line therapy is now, if you haven't received tucatinib as treatment, you get tucatinib with capecitabine and trastuzumab, or the new drug Enhertu, which is trastuzumab deruxtecan. So similar to TDM1, Enhertu is a HER2 antibody which delivers a payload of toxin to the cancer directly. So it's a very selective type of treatment, and this then becomes second or third line therapy, depending upon whether you got tucatinib or not as second line therapy. It's important to note here that both tucatinib and HER2 have been used in women with metastatic disease to the brain and have been found to be effective at controlling disease in the brain. And so as you see patients that are now getting these drugs earlier on, it does delay the need for radiation to brain metastases. And so often we use these drugs earlier on in treatment. Brain metastases occur in 50% of women with HER2-positive breast cancer over the course of their disease. It's important to recognize that the efficacy of these drugs is so incredible that the initial registration trial that led to the approval of pertuzumab, that of those women now, 8-year follow-up, 38% are still alive. And that's a large number for patients with metastatic breast cancer, but it probably doesn't reflect how high that number really is, because that 38% was before tucatinib and before Enhertu. So HER2-positive metastatic disease is truly a chronic disease, and these women deserve to have the concerns of survivorship that we have with early-stage breast cancer patients. Next. And the final group of patients, there are so many options right now for HER2-positive breast cancer, and I just sort of summarize them there, but every time we treat a patient with HER2-positive breast cancer, we do continue a HER2-directed therapy. So against all medical oncology principles, if your cancer grows after you've received a drug, this is a different situation, because whenever you move to a different chemotherapy agent, you always add trastuzumab or another HER2-directed therapy, and we have randomized trials that demonstrate keeping HER2 therapy going actually improves the duration of efficacy. Next. And the last group of patients are the triple-negative patients, and this it is 15 to 20% of our patients. We all recognize it as being the most aggressive phenotype of breast cancer. Brain metastases occur in about 45% of women over the course of their lifespan, and once brain metastases occur, the median survival is less than 6 months. So brain metastases are particularly common. This is a really aggressive type of breast cancer. First-line therapy is with a taxane, with or without immune therapy, so the pembrolizumab or not, and this is a question that is always out there in whether you truly benefit from immune therapy or not. Often we add carboplatin, which is particularly effective in triple-negative breast cancer. And patients continue on those drugs until their disease progresses or they don't respond to therapy, in which case they go to second-line therapy. So second-line therapy is currently a drug called sacituzumab. Next slide, please, Lisa. And sacituzumab is another antibody drug conjugate. So it, like TDM1 and like Enhertu, it is an antibody, and the antibody in this case is to a target called TROP2, and it delivers this irinotecan-like drug directly to the TROP2. Now, TROP2 is not unique to triple-negative breast cancer, although sacituzumab is FDA approved really only in triple-negative breast cancer right now. This is a drug that has activity in other phenotypes of breast cancer as well, but it is well established that sacituzumab is now second-line therapy. Next slide. With disease response or no response, the third-line therapy includes a variety of other chemo drugs. Next, Asa, thanks. And basically, there are a whole variety of chemotherapy drugs that are left that are potentially effective: gemcitabine, vinorelbine, adriamycin, and clinical trials. You see the star here at the different areas indicating molecular testing on the tumor or through the blood. And the value of this is that we often identify targets that we might not otherwise have identified without this somatic testing. And this also identifies patients who are eligible for clinical trials. Next slide. And the last thing that I want to talk about are the PARP inhibitors. So there are a number of PARP inhibitors on the market right now. Only 2 are approved in breast cancer, although it's hard to imagine that there's a big difference in them from disease site. But olaparib and talazoparib have been approved in the management of breast cancer. So generally, these are used as second-line therapy in women with germline mutations. So when I started, I said every patient with a metastatic cancer should undergo germline testing, and this is why, because the PARP inhibitors are particularly effective, and they may be effective with response for short duration, but I think the thing that's most impressive about the PARP inhibitors is that there is a subset of women who have truly excellent responses. I personally have a patient who's been on a PARP inhibitor from being on a trial, and she had metastatic disease to lung, and she's in complete remission now for 12 years. So the PARP inhibitors in a unique subset of women really have an incredible efficacy and duration of effectiveness. So I'm going to stop there and just transition by saying, you know, we always talk about thinking about breast cancer as a chronic disease, but the many, many advances that we've made in the management of metastatic disease really has made this a chronic disease. So thank you.
Okay, thank you, Dr. Mortimer. If we think about a really chronic illness, one of the first things we're going to think about is that it's always more than just the patient. It's the patient, the partner, and the family, and the larger social network. Next slide, please. So when we think about couples, when we think about gender, all too often we think about the schoolyard way of thinking about it. But for the last 25 years, especially, including studies from the Institute of Medicine, gender across the continuum of the human experience is more and more really relevant as we think about how do we find strengths in each other and not have the perception of these 2 lines going at it. Every time I see his face, I just wince. I'm sure he deserved everything that he is getting. Next slide. And it's really hard when someone who you deeply care about and love, whether it be a partner or a child, you want to rush in and fix it and try to make it better. But it pains me to tell you it ain't broke. And so when we think about problem solving, which is where the research is, when we think about how do we get the best out of each other, there's a way of actually doing that. And I'm going to share a program that does just that. And I'm going to tip my hand here to say we had an external company, you all know them, Accenture, come in, and when they looked at our couples program that I'm going to share with you, that is in Dr. Mortimer's clinic actually, we not only saw patients spending much less time in the intensive care unit who went through this program, but we also found that they saved the institution lots of money. Next slide, please. And we also know that we cannot talk about gender in terms of boxes. We could talk about population-based. And for those of you who do want the data on this, there is a book called Gender in Psycho-Oncology by Dr. Young-Mi Kim and me. And that is about 20 chapters on the back of data about gender and the importance of partners. But I'll share some more data in a moment also. Next slide, please. And we know that relationships, at least healthy ones, can be very nurturing on a primal level. Next slide, please. And that relationships come in all shapes and all signs. Next slide, please. Okay, so what do we know? What have we known for a very long time? What we've known for a very, very long time is that social relationships really matter. Isolation is a killer. We've known that for many, many years. So if you look at who is more likely to have decreased survival over time, it's people who are isolated. And of course, all the other things that we all know about, smoking, alcohol use. But what really has come out in the data, and this is why the program I'm sharing with you is so relevant, it's not just relationships, it's healthy relationships. And as we also know in terms of gender studies, sex studies also, is that there is a benefit to relationships to both women and men, but men do get a larger benefit than the women do. Next slide, please. Okay, so what keeps us healthy? That we can control and actually manage. And I think it's relevant to this audience because all of you see patients, all of you work with patients, and many of the things that I'm going to talk about do not cost money. They just are based in terms of knowledge and building strengths based into the system. And that is always, of course, social integration with healthy support of others, enabling people to make the adaptations that they need at work, with families, with their children, with all of their loved ones, keeping active. Emotional regulation is a major issue that many of you probably don't hear about, but emotional regulation drives perception. And if you think about your own life, you will know that your emotions are going to influence how you influence and interpret things. And that's why cognitive behavioral therapies and problem-solving therapies have such profound data behind them. Next slide, please. Okay, so relationships really matter. I think it's very hard to argue this with all of the data, but if you think about it in your own life, very few things can make you as unhappy or as happy as the health of the relationship that you're in. But cancer is superimposed on relationships. And when I talk about these really couples, I'm talking about same or opposite sex partners. But I'm also talking about if someone says they don't have a partner, they'll often bring in a sibling or friend. And so friends are less helpful than family members because of the level of commitment that it usually takes. Patients are also undermined by some partners, and it's good to know that early on so you know how to manage that. Some relationships improve and get closer, and I'm going to share some information later about how you do that. And everything I say is relevant to everyone on this call. But healthcare professionals can actively support relationships at times of change, and they can be transformative. We don't grow as a person physically or psychologically or spiritually a tiny bit at a time. We have growth spurts, and there are times that we're much more open to change and growth. But we must remember, serious illness is an opportunity to decide the life one is living beyond the one that they have inherited. And we let partners know that. Partners are underutilized. Next slide, please. Okay, illness is a life-threatening problem, but it's also an opportunity. Partners are often the primary support for each other. And that's especially true in terms of cancer because people tend to get cancer a little bit later in life. Families are smaller, so they're more dependent on their partners. And there's less social support for women from other women. This is all statistical. So really women do bear a greater burden, and families just may be isolated more. And the unrealistic high expectations many of us have on relationships. And who else is going to teach the next generation how to care if healthcare professionals don't do it? Next slide. Why don't we skip this slide because of time? Okay, so how do we find these patients? What do? We screen both the patients and their partners. If they don't have a partner, of course, we will screen a family member. We orient them to breast cancer. We educate them. We provide psychological support. We do all of this before they meet with the surgeon or the medical oncologist. and we do an exit evaluation survey. Next slide. So we've seen well over 3,000 couples now in these clinics. Most of them are in the breast clinic. That is really not by accident. Women do tend to be much more open to having their partner involved and engaged. Next slide. So here is some data. We have over 3,000 of these couples now. And if you look at in the red boxes, you will be struck by women and men, the same and opposite sex partners. They really do struggle with the same issues mostly. But you'll be struck by, of course, the patient cares more about the side effects, especially when it's chemotherapy, as you know. And then for the partners, finances are a bigger issue. This drives the interview when we meet with them so we can give them the right kinds of resources. We screen all of these patients on a touch screen that we've copyrighted. Next slide. Okay, this is crucial. Yes, we do ask at first visit. Yes, we can ask and we do ask. And we have almost 1,000 of these now, where we ask patients and partners how likely they feel cure is, all the way down to cure is not likely. Now, this particular set of questions is in the metastatic clinic. So these patients are not curable. And if you could hit for the next slide, please. We'll see what happened. If this is amazing to us, all patients are metastatic and by definition are not curable. 49% of the patients thought they were curable. Over half of the partners felt that they were curable. And most of these patients have gotten their diagnoses and prognoses in other places. So this is an opening spot for us to work with the partners. Next slide. I should say about this slide that we have not had a single complaint from a patient or a family member asking them this question. Sometimes the healthcare professionals, all of us, have a harder time, but the patients are already thinking about this. They hear the word cancer in their mind. They think about dying. So why should we let them be in isolation? If they're not ready to talk about it, it just rolls off. But we do have a strength space. When you first met, you knew this relationship would end at some point. Yes, we say that to them. And we say, and that was courageous for you to go ahead anyway. There's something powerful that happens when you bring mindfulness into reality, right? So when you react under stress, we want to do it in a way that you'll be proud. And what kind of relationship have you always wanted? Because cancer is always a crisis. So we could use that crisis to have them recommit to each other, to have the relationship for which they would be proud. Next slide. We have patients, we say to them, you always knew this relationship would end, and this is a time for you to recommit through truth and honesty. One piece of data you should all know, anyone in a relationship should know this. When you are in the midst of feeling strongly about something with your partner, that is the worst time to talk about it. The best thing to do, and this is true with staff in terms of creating programs of interprofessionals, you should schedule compassionate and courageous times to talk about how is our relationship going, what's going well, what is not, and taking the personal accountability for what you will do to make it better. Let me say that one more time. When we have couples who come to us and say she or he should do this and that, rather than I am committed to working with he or she, things change drastically. There's research that shows that. Next slide. It's important to remember that in relationship, when one person wins, the relationship loses. We give educational sheets that have been tested through focus groups and everyone gets them to take home. We ask them to put them on the refrigerator. Next slide. And there are benefits to patients and families that more issues are addressed up front, honestly and openly, and we access the courageous, healthy part of people. And we have people more actively participate in their care. We do not treat patients like victims. We treat them like partners in their care from the very first meeting. that they truly feel cared about and valued as people, and to get on with a living non-cancer focused life based on personal aspirations and goals. We triangulate the cancer experience. Cancer is the problem, not you, not me, not the patient. Let's focus against the cancer together. Next slide. Okay, and of course it jumps out at you that if you're talking openly, at first it's going to be scary and unpleasant, but there will be less fear, less social isolation, and less stigma. And who wants to feel any of those things when you already have a life-threatening illness that you know cannot be cured? Next slide. So one thing that we have found, it is feasible to provide and we've been doing this now, our gender program for over 14 years, and this particular one for about 7 years. It's feasible to provide a psychoeducational intervention followed up by couples counseling for high-risk couples and integrating that into an interdisciplinary team into the flow of the clinic. It takes about 25 minutes for the first intervention. Next slide. Okay, and I'm going to end now with some actual quotes. These have not been cleaned up or touched. Oh, is that why he does that? I never would have guessed. Next. How can she not know I love her? I am here. Next slide. We've been married for 50 years and we've never had a conversation like this. Next. If I would have known how to talk like this, I might still be married to my first husband. The person actually told me that. Next slide. Enough of him sharing his feelings already. I want my man back. I have feelings too. Next slide. Illness is an opportunity, though a dangerous one. Illness takes away part of your life, but in doing so, gives you the opportunity to choose the life you will lead as opposed to living out the one you have simply accumulated over the years. Thank you very much. I'm sorry.
Say to everyone who's on the webinar that I'm very honored to be able to speak to you. You're a very illustrious group, and I'm hoping that as a metastatic breast cancer patient, you might learn something new from me. The first slide, the comparison from early stage and metastatic, is that up? Hello?
Yes.
Yes, that's up.
Okay, very good, thank you. Okay, I created this chart some years ago when I tried to help other metastatic breast cancer patients educate people about the difference between early stage and metastatic disease. I'm not going to cover every item on here because some of this was covered earlier by Dr. Mortimer. But if I bring your attention to metastatic breast cancer, as she said, the disease is most common to bones and brain, liver and lungs. But I want to add for your information that beginning in 2015, another type of histologic subtype started to enter clinics, and that is called lobular breast cancer. And probably all of you know, ductal metastatic disease is the most common, but lobular means that the cancer cells started in the lobes. And this is a very challenging subtype to have. I think there about 5% of patients have it, but the problem is it does not show up well on scans. It does not form a lump. The cancer cells are like in a row, like a railroad, and the cancer goes to different websites, such as the gastrointestinal tissue, ovaries, visceral organs. And so right now, many of us are encouraging research to try to help radiologists have a better means of identifying progression of lobular breast cancer. The other item under that says that how many people are living with metastatic disease. Today, we estimate about 178,000 are living with metastatic breast cancer in the United States. And you'll notice here in this chart, it says counted only if de novo. In early stage breast cancer, everybody gets counted by the SEER which is a government organization. The SEER, it stands for Surveillance, Epidemiology, and End Results. So when I was diagnosed with early stage in 1991, I entered the SEER data. My subtype was recorded, my first treatment, and then the next time I would enter this, the SEER data would have been when I died. When my cancer returned 12 years later, I'm not included in the SEER data. So this is a real shortcoming of our epidemiology in the United States, and many metastatic patients are trying to change this. The other factor I'd like to show you here is that under the treatment goal, when metastatic patients are first told they have the disease, certainly it's like a time bomb, you're in shock, and you keep thinking about, well, okay, what do I do to get cured? And it takes a while for most patients to understand that the goal of treatment is to control the disease and maintain quality of life. And then finally on this chart, if we look at survival rates, with treatment for early stage, 99% of people who have early stage locally will be still alive 5 years later. Whereas with metastatic disease, after 5 years, the survival rate is only 28% in women and 22% in men. And finally, what I'd like to show you or inform you about is that when we look at breast cancer research, and the Metastatic Breast Cancer Alliance did a very thorough job in 2014 of analyzing all funded grants, both by the government and private sources like Komen, others, DOD. They found that only 93% of all breast cancer research was devoted to early stage prevention, etc., and that only 7% of breast cancer research was dedicated to metastatic disease. And this is another area that we advocates are trying to change. Next slide. So this slide, the important thing I'll just focus here is the first statistic. Many people have the impression that if you go through early stage disease, you're cured. And the truth is that we found now out that there are estimates that anywhere from 10 to 30% of people who have early stage disease will have a recurrence that is metastatic. So when patients go through early stage disease, we are encouraging their oncologists, their surgeons to say, you need to be aware of having regular checkups for your cancer. Next slide. So how does a metastatic breast cancer diagnosis impact the person? Obviously, the most obvious is that we lose our good health. As we've heard, metastatic breast cancer is treatable but terminal. It is not yet chronic. You know, it would be nice if it was chronic, because like diabetes or other disease, you could live for years and then die of something else. We would like to get to that point where it is chronic and then ultimately occur a cure. With the disease, some of us lose body parts. In my case, when I had early stage disease, I chose to have a double mastectomy because I thought by doing so, I would be cured, and I had 2 little boys to raise. Something like mastectomies or other lymphedema, etc., can have effects on marital relationships. Women who have metastatic disease often do not know whether they should date, or if they do meet someone, should they tell them about their disease? It becomes very complicated. And even with friends and relatives, telling someone else that we have the disease can be very anxious, cause anxiety, especially when we say to someone we love or a friend, I'm told I'm not cured and never will be. And then someone might say, you mean you're going to die of this disease? Well, yes. And people, at least in our country, are not very comfortable talking about death. So some friends will keep because they choose to stay, and others they will let go. For other metastatic patients, the disease can impact their job, whether they can hold on to their job because of their treatment, appointments, toxicities, and in some cases, people have to give up their career. And since most of you are aware that a majority of Americans receive their health care through their job, this presents a great challenge to metastatic patients. After 2 years, the law says that I, as a metastatic patient, could qualify then for Social Security and Medicare treatments. Right now, there is a policy that's trying to change that so that those who have metastatic disease can immediately become part of Medicare. And certainly a huge issue for metastatic patients is financial toxicities. Drug costs just keep rising. And this is a growing issue with patients. And I'm sure any of you who have had any occasion to look at what the price of a drug is, some drugs cost $12,000, $16,000 a month. And for patients who do not have any health care in those states where they do not even offer Medicaid, there are just really sad cases where people cannot always get the treatment that is best for them. And finally, we all who have children, when we get a diagnosis, we worry about their future, who will take care of them. And when we get to the point, we think, well, when my treatments are going to stop working, death is around the corner, and we have to think about how we're going to handle that. And we certainly have to come to terms with our life as we go throughout our treatment journey. Next slide. What is the public's reaction to metastatic breast cancer? I really wanted to mention this to all of you. For years, as you all know, the month of October is devoted to Breast Cancer Awareness Month. And the mantra, and it's a good one because I had early stage and I did have mammograms, but it said a mammogram will save your life. Well, we know, at least I've learned, that that's not always true, that your disease in the metastatic disease can come back 5, 10, in my case, it was 12 years. People will say, if you catch it early, you're going to survive. What that means, catch it early, because, depending on the type of breast cancer that you get, that will influence whether it's going to be a very quick growing, hard to treat type of cancer. And then in the month of October, for years, there are celebrations for survivors, and metastatic breast cancer patients have had to stay hidden, out of sight, because oftentimes we were seen as people, well, you didn't do the right thing. You didn't get the right treatment, and that's why you got your disease. And then finally, the whole issue of how funds are raised for breast cancer. Does anyone care to increase the percentage of research funds for the disease that kills? And finally, I have to say that among early stage breast cancer patients, while they can be very friendly and kind, they also have a feeling that they really want to stay away from metastatic patients, because it's like, I don't want what you have. Not that it's transmissible by association, but it reminds patients of the disease. I want to share with you that a week from today is October 13th, National Metastatic Breast Cancer Awareness Day. This is a very special day to my heart, because as a political science major, someone who loves the law, I realized in 2009 that we had to do something very different if we're going to bring the word metastatic breast cancer to the month of October. And I was able to contact a senator from Indiana, where I was born, whose mother, Marvella Bai, had metastatic disease. And I asked Evan Bai if he would introduce a resolution such that the Congress would pass a resolution declaring October 13th as Metastatic Breast Cancer Awareness Day. And that happened in 2009. And I hope that in your breast center, you will acknowledge on October 13th that that is a day that finally people can talk about, or they can talk about it every day because we have the disease every day, but that is one day in the month that is set aside to recognize metastatic breast cancer. Next slide. So what are our unique needs? I'll go through this rather quickly in the interest of time. Again, getting a diagnosis of metastatic breast cancer is like a bomb, especially when you're told there's no cure. Psychological support, and that is the theme of my talk, is critically important. I found a research study by David Spiegel, who determined in his research that if the symptoms of depression symptoms of women who were first diagnosed with metastatic breast cancer were addressed, that they lived longer than people, women whose symptoms of depression were not addressed. So the mind and the body, I think, are very much connected. And I would urge all of you in breast cancer centers to offer support to metastatic, offer the kind of support that you and your breast cancer center offer to early stage breast cancer patients, to metastatic breast cancer patients. I think every center should take a holistic approach, both to early stage people and to metastatic people, because the body and the mind are connected. The problem that we face as metastatic breast cancer people, the obvious one, is that our treatment will never end. We have to come to grips with the end of life, and yet we have to make each day count. I don't practice gloom every day of my life. I see each day as an opportunity and live in that day. But not all patients get to that point right away. So the staff at your breast center should communicate with patients who have metastatic disease in a very open way with knowledge of the disease and try to assess them emotionally. And finally, I believe that it is important for breast cancer centers to work with advocacy groups to access information about the disease. And I want to compliment the NAPBC for doing this. Otherwise, I wouldn't be here today. There's a whole group of advocacy groups that the NAPBC has worked with, and that's why we're here. Next slide. So what kind of care team do metastatic breast cancer patients need? I drew upon the saying that I guess it was Hillary Clinton used for her political campaign. Others have used for child raising. It takes a village to provide whole person health care, a multidisciplinary team. And so I've listed a number of such people you see on this slide that are part of a team. And I really want to draw attention to the pathologist and the radiologist. These are two positions, and if any of you are out there listening to this, I want to thank you for what you contribute, what you've contributed to my life and other people's lives who have metastatic disease. Because these two positions, we have, a lot of patients will tell you they've never met the pathologist that identified their subtype. Or if their subtype, as Dr. Mortimer pointed out, and it happened to me, if your subtype changes, wow, that is so important to informing treatment together with the oncologist. So pathologists, I take my hat off to you, though I never have seen you. And radiologists, the same thing, because it's that scan, whether CAT scan, PET scan, or whatever, that is so important to inform the rest of these people how the patient is doing. Next slide. So what I did in preparation for this talk is that I did look at the NAPBC patient forms. And there are two forms that I want to address. The first one is called Your Healthcare Contact List. And I think it's an excellent for all stages of breast cancer patients. It lists for the patient the various places for them to add contact information, phone numbers for primary care doctor, oncologist, etc. And I was so glad to see that a primary care doctor was listed among those groups of people, because even though I have metastatic breast cancer, I may get diabetes, or I may have high blood pressure, or I may have something else. So you really should not depend on an oncologist to be your go-to person for everything. And then the second document on that, those NAPBC forms, was called the follow-up care plan. There I have two suggestions. It refers on that page to breast cancer survivors. I ask you to consider instead saying persons who have been treated for breast cancer. Metastatic breast cancer patients do not consider themselves survivors. Some of them call themselves thrivers. Some of them just say, I'm living with metastatic breast cancer. So if you want that form, if you give that follow-up care plan form to all of your patients, including metastatic people, please consider changing that word survivor so it's good for everybody. And then it says on that sheet, here is a list of resources and support groups available to assist breast cancer survivors. Again, I ask you to consider, please, saying here is a list of resources for people who have had breast cancer. Then the form is appropriate for everybody. Next slide. So what approaches, in conclusion, help metastatic breast cancer patients?
Shirley, this is Dr. Salmschmidt, and our time on the webinar is wrapping up. Can you finish it up in about 30 seconds?
Sure. I ask that your staff understand metastatic breast cancer and demonstrate their understanding when they interact with patients. Please understand that the psyche and the physical body of patients are interconnected. Ask people how they're doing and be aware of signs of distress, anxiety, or depression, and then make referrals to appropriate resources. Next slide. And so in closing, at breast centers where a caring professional staff understands the challenges facing metastatic breast cancer patients and seeks to observe and address each patient's physical and emotional needs, then patients have the potential to live longer and with a better quality of life. I thank you very much for the opportunity to speak with you.
Shirley, that was amazing, and I wish we had loads more time, but we really don't. So a big thank you goes out to our moderator, Sally Werner, and all our presenters, and all of you, our participants today. What a great webinar. We want your feedback, and we'll be sending you an evaluation form via email. So please let us know how we're doing. If you have questions, go ahead and put them in the system now, and we'll answer them later. CE, CNE, and CME can be obtained for this webinar, and this email will provide instructions, and the website for the American College of Surgeons Learning Management System is www.learningfacs.org. Next slide, please. Stay tuned for further NAPBC webinars and other cancer program events that might interest you. These events can be found on FACS Quality Program Cancer Events. And once again, thank you. For those of you who want to stick around, we're going to try to answer some questions now, but I want to make sure I get this information out to you. Take it away, Sally.
Thanks so much, Dr. Salmschmidt, and to our wonderful panel. We recognize we're out of time. If you're still on the webinar and want to ask a couple of questions, we can do that now. Okay, I think we're going to go ahead and wrap it up. Thanks so much, Dr. Mortimer and Matt.
Thanks to everybody. Really nice job. And Sally, thanks to you. Those were great suggestions for the NAPBC. All right. Thanks, everybody. Have a great day.